Next 20 minutes, I will remind everybody of the renal physiology and hopefully convince you that we need to change our criteria for acute kidney injury so that we can improve the management of this condition. These are my disclosures, and they've not influenced this presentation. The term acute kidney injury describes a syndrome consisting of hundreds of different conditions that are all characterized by the fact that the creatinine may go up or urine output may fall. And this syndrome, acute kidney injury, is clearly very common in critically ill patients, and it's associated with an increased risk of mortality and an increased risk of serious long-term complications. And that's why we need to focus on this. At the moment, we do have no particular specific therapy for acute kidney injury. We treat all patients with acute kidney injury more or less the same. And by reviewing the physiology and the pathophysiology of acute kidney injury, I can hopefully convince you that we need to, in future, look at different subtypes so that we can improve our management. Just in the next few minutes, I just want to convince you why the kidneys are so vulnerable in critical illness, in so many different conditions that all cause and are associated with acute kidney injury. So as you all know, the kidneys are very vascular organs, and in health, they receive around 20% of our cardiac output. This can be less, but it can even be more when we're critically ill. Ultimately, the kidneys consist of up to 1 million nephrons, and these nephrons are working units with a very close relationship between the tubular structures and the surrounding blood vessels. And in fact, functionally, we can distinguish between two types of circulation. We have the glomerular vessels and the peritubular vessels. Now, they're clearly linked, but functionally, they're very different. So the glomerular vessels are responsible for glomerular filtration, and our peritubular microcirculation is responsible for reabsorbing more than 99% of the glomerular filtrate, more than 99% of the water, and numerous other essential nutrients, amino acids, electrolytes, and so forth. Although the kidneys receive a huge amount of blood volume, about 20% of our cardiac output, the majority stays in the cortex and in the medulla, where most of the metabolic activity occurs. Only around 15 to 20% of blood is received. Now, the kidneys make up for this by having the tubular structures really surrounded by blood vessels, as seen here. But despite that, even in health, we have a very hypoxic milieu in the inner medulla. This is in health, but the tubular cells are able to function despite this very low PO2, this very low oxygenation. But it also means clearly that the tubular cells are very vulnerable to any condition where oxygen delivery to the nephron or to the tubular cells is impaired. I already mentioned there are functionally two different types of vessels, and we have the glomerular vessels that are responsible for glomerular filtration. They generate a pressure gradient between the two blood vessels, the afferent and the efferent branch. And all this is fine when people are well, but during critical illness, in particular during sepsis, the hemodynamics change and the pressure gradients change. And on top of that, when we're ill, in particular in conditions with inflammation, pre-existing shunts open up, and they suddenly open up and completely bypass the glomerulus, as seen here. And when this happens, glomerular filtration can cease completely. The peritubular microcirculation is very vulnerable to conditions associated with reduced oxygen delivery, but it's also very vulnerable in any other condition that it's associated with endothelial dysfunction, so inflammation, sepsis. Whenever we have endothelial dysfunction with permeability problems and disturbances in blood flow, this all happens in the peritubular microcirculation and impacts the oxygen delivery to the tubular cells. I showed you the picture with the tubules being surrounded by blood vessels. That's essential, but clearly if the blood vessels look like this, with leaky walls, small microthrombi, and impaired blood flow, it's ultimately the tubular cell which suffers. So if you put this together, we have the glomerulus in critical illness, which is exposed to all the various toxic metabolites and inflammatory mediators that get filtered, as long as there is still ongoing pulmonary glomerular perfusion. These various cytokines, inflammatory mediators, and metabolic waste products essentially flow down the tubule and then cause damage to tubular cells from within the lumen, and they're directly tubular toxic. This alone can cause tubular injury. When tubular cells suffer, they send out triggers to the surrounding microcirculation, and the already ongoing peritubular dysfunction gets even worse. On top of that, we may also, obviously, as I already said, have shunt, and the whole blood supply to the nephron may be impaired. So this is one of the reasons why glomerular filtration may cease and tubular injury may occur. When people are ill and the kidneys receive some blood supply, they will also receive the systemic inflammatory cells. And on top of that, they will activate inflammatory cells within the kidneys. And as a result, the kidneys actually induce inflammation. So injured kidneys induce inflammation and produce inflammatory mediators, which get then released into the systemic circulation again. Finally, we've now learned that the kidneys are very vulnerable to mitochondrial dysfunction. And in fact, mitochondrial dysfunction is something that occurs very commonly when the kidneys get injured. In health, we normally have a nice balance between mitochondrial fusion and splitting. But in acute kidney injury with injured tubular cells, this balance is disturbed, and we essentially end up with fragmented mitochondria in these tubular cells. And as a result of this, ATP production is impaired. And if this carries on and is very severe, the tubular cells may actually die. And the fact that this happens has been shown in several recent studies. I just show you one here. This is a rat model, experimental model, a pre and post ischemia tubular cells. We can clearly see differences. And in vivo imaging show these changes were due to mitochondrial dysfunction. When the mitochondria don't work properly and are small and fragmented, as I've already mentioned, ATP production goes down and the tubular cells suffer further. And lastly, when tubular cells are not happy and are being injured or are not receiving adequate oxygen delivery, they start trying to they try to protect themselves and essentially down-regulate various processes and go into a form of cell cycle arrest. Now, this is all done in an attempt to survive. And occasionally, as long as the damage and the insult stops, the tubular cells recover again. But if this carries on for longer, the cells essentially become apoptotic and fibrotic. So these are the things which can happen in patients who are at risk of acute kidney injury. And this can happen in the kidneys when exposed to nephrotoxic insults. What we now know is that different pathophysiological processes occur depending on the triggers. And just as an example here, where you have an experimental model investigating the common scenario of cardiorenal syndrome, so cardiac impairment and acute kidney injury. Now, you may have cardiac impairment for different reasons, either as a result of coronary artery disease or a cardiac arrest or going on to bypass. And in the experimental model, these different forms, all leading to impaired cardiac function, had different effects on the kidneys and triggered and activated different processes, and also led to the activation and release of different biomarkers. And just look at this more closely. If you look at when investigators looked at different experimental models, they noticed that an AKI model caused by hypovolemia, something we see very often in clinical practice, led to the activation of various metabolic processes like gluconeogenesis, but also the activation of anti-inflammatory molecules. And histologically, when the animals were sacrificed, the changes were in the inner medulla. But experimental models of AKI caused by clamping of the renal artery led to very different pathophysiological processes, metabolically and also histologically. And when they compared them, it turned out that less than 10% of common gene activation could be seen. So depending on the trigger leading to acute kidney injury, different processes occur and different pathways are activated. And apart from hypovolemia and ischemia, investigators have also looked at other forms of experimental models. And as you can see here, clearly, not only different genes get activated, but also other important metabolic processes. Now, this is important because it highlights that every form of AKI is actually different, but it also opens the door to potential therapeutic options. And clearly, if we want to look for a therapy for a type of AKI, then it's important that we know the underlying pathophysiology and then identify the important key steps. But it also means that not every potential therapy is potentially effective in all types of acute kidney injury. Now, I've highlighted the pathophysiology. Now, the whole thing is obviously confounded by the fact that patients are also all different and come with different comorbidities. So some may have pre-existing CKD, where all the processes which I explained earlier on may be impacted by pre-existing fibrosis. There may be more than just one insult. Patients may have sepsis and additional tubular injury from toxic drugs. There may be drugs affecting the kidneys from different angles, some causing direct tubular injury and others may cause intratubular obstruction. And then on top of that, we've learned that fluid overload and right-sided heart failure can also make things worse. So the kidneys don't like to be dry, but they certainly don't like to be overloaded either. And in fact, renal congestion has now been acknowledged and appreciated as a cause of acute kidney injury and as a trigger to progressive acute kidney injury. The kidneys and the brain are surrounded by either a tight capsule or the skull, so they can't dilate and they can't expand. So for the kidneys, this means if in cases of congestion, the intratubular and intrarenal pressure will go up, and this will lead to direct compression of veins and nephron structures. So this brings me back to the original slide. We have so many different causes of acute kidney injury. Some are more common, but others may also occur, and some occur in combination. And we have all these different pathophysiological pathways that may be activated in sequence or at the same time. And that's why it's been so difficult, in my opinion, really to find a therapy for acute kidney injury. The search for therapies is confounded or complicated further by the fact that we don't have good markers to tell us about the exact cause of acute kidney injury and the underlying key pathophysiological processes. In clinical practice, we can only detect acute kidney injury when the creatinine has gone up or urine output has fallen, for whatever reason. We have currently no tools to give us the specific underlying cause that may be the cause of acute kidney injury in patients with heart failure. And that's often very different from acute kidney injury in patients with liver disease. And even if we knew that a case of acute kidney injury was caused due to one particular etiology like sepsis, it now turns out that every case of sepsis-associated AKI is not the same. Here we have some results of the Finaki study, a remarkable national study from Finland, where they collected data of patients in all ICUs in Finland and also collected some biomarkers. And in this study, they looked at patients who looked to the clinician at the bedside, all like having AKI as a result of sepsis. So phenotypically, this was septic AKI. And when they looked at the biomarker set and did some advanced statistical testing, they identified two subphenotypes. And as you can clearly see, they were very, very different with regards to their clinical parameters, their biological parameters, and their biochemical parameters. But to the outside world, to the clinician at the bedside, they looked the same. Now, these two subtypes of acute kidney injury in the context of sepsis were very different, not only in the way they responded to therapy, but also with regards to prognosis. And subphenotype 2 clearly had a significantly lower risk of regaining kidney function. Now, is this important? It is very important. And the fact that this may be important for future management was highlighted by this sub-study, where the investigators from California looked at a database with data of patients with either ARDS or sepsis. And again, they used the same approach and tried to find subphenotypes of acute kidney injury in the context of either severe inflammation or ARDS. And they identified, again, two different subphenotypes, different from the Finnish study. These were two different subphenotypes characterized by differences in the endothelial and inflammatory biomarkers. And not surprisingly, similar to the Finnish study, there were some differences in the prognosis. So patients with subphenotype 2 had a worse mortality and a much lower risk of recovering renal function. Now, they used the same approach and applied it to a different database. This was the VAST study comparing vasopressin versus noradrenaline in patients with septic shock. And by doing that, they were still able to find these two subphenotypes. But they also showed that subphenotype 2 really, they made no difference whether the patients had received vasopressin or noradrenaline. But for subphenotype 1, there was a huge difference. And they clearly benefited from receiving vasopressin. And what this shows is that different subphenotypes may not only be different in their underlying pathophysiology, but they may have differential responses to therapies, in this case, vasopressin. So we are dealing with a syndrome that gets really defined only by creatinine and urine output, but depends on so many different factors and has so many different underlying pathophysiologies. And the lack of tools to identify the pathophysiology and to tell us and what the main etiology and pathophysiology is, has led to the fact that when we study therapies, we apply them to anybody who has AKI, instead of identifying those who are likely to respond most and leaving them out in patients who may not benefit or may come to harm. And this brings me to my final slide. I hope I've convinced you that the pathophysiology of AKI is very multifactorial and depends on the trigger and other surrounding risk factors. But we urgently need to make advances in precision medicine and identify subphenotypes that respond well to specific therapies, and also subphenotypes in whom these therapies should be avoided, so that each and every nephron can be protected in future. Thank you very much for your attention.